Good morning once again to all the connected centers across the country. We are starting the session now. We request the Torrent team to invite all the doctors to come inside the hall and be seated immediately. If they are having tea or coffee, they can carry the cups inside the hall because we are starting right now in the next 1 minute. Thank you. Good morning to all of you doctors seated here in Mumbai and also across the length and breadth of the country in 14 other city locations, and also hundreds of pediatricians who are connected through the virtual link to this scientific event. I especially extend my respect and welcome to Dr. Amdekar sir and also to Dr. Chokhani sir and all honorable pediatricians across the country. On behalf of Torrent Pharma, the sixth largest pharmaceutical company in India, myself, Sumit Roy, General Manager, would like to welcome each and every one of you for this live CME program. Torrent Pharma, as is known to you, is the flagship company of Torrent Group and is one of the leading pharma companies in the country with a presence across practically all therapy segments now. Our competitive advantage stems from our world-class research and manufacturing facilities and also an extensive domestic network supported by a global presence as well. Science has been at the fulcrum of all our endeavors in Torrent. Therefore, when Clinics India team approached us and shared this proposal of this scientific event, we immediately gave our consent to support this scientific program in the field of pediatrics. Today is a special day for us at Torrent as we have Dr. Amdekar sir and Dr. Chokhani sir, probably for the first time in a scientific program where we have been a part of it in a supporting mode. I would like to welcome all the delegates who are seated here in front of me, and also in particular, each one of you across the country who have taken your time out on a Sunday morning and to attend to this academic fest. I would also like to welcome around 400 doctors. That's the count which I got before the meeting we started just now, who are watching the event live across the country. In addition, hundreds of those who are connected through the web link. With these few words, now I request Dr. Anupam Agarwal from Clinics India to take over the faculty introduction. Over to you, Dr. Agarwal.
Good morning, friends. I welcome you all again to today's live interactive CME on rational approach to diarrhea management in children. I am Dr. Anupam Agarwal from Clinics India, and we are organizing this event with our digital platform dockidslive.com with an educational support from Torrent Pharmaceuticals. So thank you, Torrent. I am lucky to have been given the task of introducing the faculty, though you all know, being pediatricians, that they don't need any introduction. But still, I have to do some formality. The faculties for the day are Dr. Y.K. Amdekar and Dr. Rajesh Chokhani. The more we say about them, the lesser it is, as you know. Education and teaching has been their passion. The commitment, consistency, and perseverance they have towards education and teaching is impeccable. Clinics India is associated with Dr. Y.K. Amdekar for last 13 years. Whenever I go to him, his one-liner has always been that if it is for education, I'm for it, go ahead. This is the kind of passion he has towards education. And he has a time punctuality as well. Whenever, in fact, when I went to him for the agenda for today's meeting, wherein I had kept 45 minutes for these formalities like, inaugural address, welcome address, then felicitation and all, then he said, why not to start the session immediately? Why are wasting your time in formalities? So I had to cut short that 45 minutes into 15 minutes. So I won't take just not more than 2 minutes. Now the formal introduction. He is a practicing pediatrician for last 50 years in Mumbai. He is currently a visiting consultant to SRCC Hospital, Mumbai, has been the faculty to Grand Medical College, JJ Group of Hospitals, and Institute of Child Health. He has been the past president of IAP as well. So whatever I have said above goes equally well with Dr. Chokhani as well. He's another gem with us today from the Faculty of Pediatricians. He's currently the president of IAP Mumbai and consultant pediatrician with Hinduja Hospital. He is the examiner of MRCP CH, Royal College UK, also the examiner for DNB, FCPS, DCH exams. He has been the faculty to various conferences at national and international levels. So with this brief introduction, we have been restricted to just not take more than 2 minutes of the introduction. So with this brief introduction, I invite the faculty and senior members from Torrent to participate in lamp lighting ceremony. And after that, we'll do a brief felicitation, and then the floor will be yours, sir. Now I request Mr. Sumit Ray, General Manager, to please felicitate Dr. Y.K. Amdekar, sir. Please do that. Now I request Mr. Ray to felicitate Dr. Chokhani. Please give a good. All done. So now the floor is yours, sir. Dr. Amdekar and Dr. Chokhani.
Good morning, friends. We are not going to talk anything great about science that you all don't know. Only because we also don't know much. But I thought that we will revise our concepts in a manner that we could do the best to our patients. And that's why this is an interactive program again, and feel free to kind of differ from us, put your views, and when everybody talks, everybody will learn. And that's the way we go about that. Just quickly revising the basics. Okay. Let's get about revising the basics. We know diarrhea is a change of bowel pattern. Okay, if I'm used to pass 3 stools a day all my life, that's not diarrhea. Okay, so take a note of that. But usually, yes, we know frequency, consistency, etc. But what is more important is, do I look sick by those kinds of 2 stools? If not, you might give a thought, why I'm not sick, even when apparently I have a low stool. So take a note of that. Then, of course, the causes could be many. There could be a maldigestion. There could be, of course, malabsorption due to varieties of reasons. It could be underfeeding, it could be overfeeding, so multiple things. And then the next, what is more important is watery large stools with dehydration. You have a acute small intestinal problem. You have the chronic small intestinal problem where it may not be all watery, but what is more important is it's producing malnutrition. And then, of course, large intestinal mucus. Any thought why small intestines, which are large in length, produce large watery stools, and a large intestine produces only infrequent small number of stools? What must be happening?
Small intestinal diarrhea is a secretory type of diarrhea.
Water is absorbed more in small intestine.
So good 80% of water is getting absorbed there, and finally the large intestine gets only small amount. So whatever the irritation, whatever the problem, you can't have too many. So we could define anatomy just by that. Of course, we can go subsequently further, and if you have a B12 not getting absorbed, where is the anatomy in the intestine? Many things are getting absorbed way up all over. But suppose you have an isolated B12, then you start thinking, where is this B12 getting absorbed? Yeah, so again, take a note. Specific things may get absorbed in a specific area of the small intestine, and we might look at that again. And of course, we know all that. But what is more important is it's not only infection, it's not only non infective inflammation, but many non inflammatory problems also, like drugs, enzyme deficiencies, hormones, many of this cause. And we will quick also look at case scenarios, which each of them, which might give us an idea how we should look at every diarrhea, not blindly as an infection or inflammation, but many other things.
So what is important in this is we knew all this, but now we have to make it a habit to approach it from the clinician's angle. So the clinician will get those clinical patterns of stool from which we have to go to the anatomy of the disease, then try to define any of these pathologies which will lead us to the possible cause. So we have to cultivate that habit of going from the clinician's angle. In theory, we know that these are the causes, these are the types of diarrhea, but we have to identify that secretory diarrhea, identify that exudative diarrhea clinically.
And that's how the clinical bedside medicine becomes interesting, because if you saw 5 children with diarrhea, all 5 could have something different, and you enjoy practice. Okay. And unless you enjoy practice, you can't do the best. Otherwise, it's a routine. Okay. Every fever gives you some different ideas. Every diarrhea teaches you something different. And you get a thrill of learning something. And that keeps our going over. Otherwise, 55 years of practice, I must be doing the same thing. But even today, I find something new, something that I never had thought, something that I would have not thought and never learned. And I think that's the beauty of clinical bedside medicine.
So we'll start with interaction. All of you.
Are there the votings? Okay.
Okay. Has everyone scanned the QR code? There's a QR code on your table. Just scan it.
So that you will do the polling.
There is a QR code paper. Request everyone to please scan the QR code and the microsite will open. My request to everyone, please keep this page active. So as sir will flash a question on the screen, the question will appear on your mobile screen also. Done?
Has everyone been able to scan?
Yeah, please don't switch off the phone. Yeah. It's done? Okay. Yeah, the question will appear.
If anybody wants help, please. Oh, he's there.
Prashant, udhar.
Single watery to single normal school. None of that. None of that. May present as frequent normal student. किसी पेशेंट को इरिटेबल बहुत सिंड्रोम है बार बार जाएगा नॉर्मल सिंगल वाटरी कैन बी राइट ऐसे डायरेक्ट सर्च कर दे मतलब ऐसे होगा
Okay, everyone is set? Yeah.
Single school can be diarrhea. इसमें बोला इसका स्टैंडर्ड वर्जन पूरा थैंक यू क्वेश्चन करा दिया तो मैं देश का है
Okay. So this is just a warm-up round. So we just discussed. So which of the following statement is wrong? Diarrhea may present as frequent watery stools, single watery stool, frequent normal stools, or none of the above. So which of these statements is wrong is what you have to say. And your voting time starts now. Whatever you think is the right option on your screen, you click on that option. Don't put that number or that letter A, B, C, D. Just click on that option. Okay. So we have a lot of participants from the other viewing centers as well. And we've got a divided house. Okay.
Probably sometimes when we give an option, the last option is difficult to understand. That's why possibly we have various options for that. So take a note of that, I'm sure. But all of you know frequent watery stool. Please, can we get back to the slide, please? Yeah, which of the following statement is wrong? Obviously, frequent watery stools is not wrong. Okay. I know that there could be a little misunderstanding when the whole thing comes up, but on some of these interaction, there would be none of the above or so. So take a note of this. But what do you think is the right answer?
So is single watery stool diarrhea or not diarrhea?
It is diarrhea, absolutely.
Okay,
isn't
it's
it?
diarrhea. Frequent normal stools?
That's also diarrhea. All right. So now the question is, do you give lot of importance to consistency or frequency? That's number one. And second, of course, you may have liked to know how sick is the child, how good the appetite is. But forget that for a while. What is more important, frequency or consistency?
Either of them.
Just
Yeah.
give a thought. I said to begin with, I have been passing 3
think
schools a
both are
day ever since.
Yeah, but
That's normal for me.
sir is saying between the two, which is more important. So somebody has frequency, but consistency is normal. Somebody has consistency loose, but frequency is only one. So which of the two is diarrhea? More diarrhea. Consistency is more important.
Okay, the point is, really what is more important is the change in the bowel pattern. But a liquid cannot be just a normal pattern. Okay, frequency could be variable. And one stool usually, 2 stools not unusual, 3 stools occasionally. Okay, we just wanted to give a thought because many times the parents would come with a statement which itself is wrong. And then we start, like, I have a cold and cough. Then I ask, nose is running? No. Nose is blocked? No. Cough? Does he cough? No. I feel there is a lot of cough. No, he feels there is a lot of cough. So he tells me he has a cough. So that's the reason. Let's go further.
Okay, which of the following statement is wrong? Maldigestion may be caused by disorders of stomach, liver, pancreas, intestines, and none of the above. And your voting time starts now.
Meditation is caused by disorders of stomach. Constipation may be caused by disorders of stomach. Yes. Because of liver. Yes. Pancreas. Stomach हो सकता है indigestion ना. Stomach में digestion बिल्कुल नहीं होता. But चलो मैं भी ये डाल दे रहा हूँ.
People are still voting from the other centers. We'll just wait for 10 seconds. Okay, so the majority have voted for none of the above as the statement which is wrong. So can you explain why? Why is that statement? So maldigestion can be caused by all others, you feel? So give an example of anyone. Somebody said even liver is wrong. So can you give an example how liver can cause maldigestion? Anyone? How can a liver disease cause maldigestion?
So I think the issue is, let's understand what is digestion. Okay. So when you take a raw material, okay, you have protein, carbohydrate, fats, etc. But that proteins have to be broken down to amino acids. The carbohydrates have to be brought down to monosaccharides. The fats have to be broken down to fatty acids. That is digestion. And unless that is done, absorption cannot occur. Same thing about our knowledge. Information has to be digested. Then only it's absorbed. And what is digestion of information? Putting information into knowledge. Then it is absorbed. Then it has to be retained. And then it has to be used as and when necessary. What a long process. Same thing is about the diet also. You need to digest. Enzymes are coming from all over. Stomach, okay, liver, hepatobiliary, pancreas, and of course intestines. Every one is important. In fact, right from saliva is also important. Okay. So the indigestion may start from anywhere. And I think that is what we wanted to say that. Okay. Earlier generation thought intestines must be kept fine. And we knew that liver diseases also come with some changes in the bowel pattern because there is a digestion problem. So again, when you have a diarrhea, it's not only malabsorption, but it starts with maldigestion. And if digestion is all right, the question is it absorbed or not? And if absorption is all right, it is retained or not? Okay, so that was just the concept we were building.
Yeah. So I think all of them, even liver, if there's a problem with the bile, then your fats will not be digested and so on and so forth. So all of them are important. Okay. Now we come to the clinical approach to diarrhea. So first step, of course, is to confirm diarrhea. Second is to, in your mind, define whether it's acute or chronic. So how would you do that? Is there a perfect demarcation line, or what is the concept?
For example, a breastfed baby has 20 loose stools. I'm sure all of us have seen, as pediatrician, mother comes and says, at one time there were two patients, freshly babies, new mothers. First one came with 20 loose stools. I convinced her how it is normal. The next one came with one stool every 4 days. I convinced her as normal. When they talked to each other outside, they waited to see me again. They thought I've gone senile. I have not understood the problem. Okay. How do you know breastfed babies 20 stools a day is normal? There is nothing to go back. Okay, the baby is only a week or 2 weeks old. There is no past history. How do you know that is normal?
You can check upon the urine output and the weight gain or weight loss associated.
Urine output. But don't forget that in a small infant or a neonate, the renal concentration ability is not much developed. So every child at that age is passing too much of urine. But point is then, weight gain in the first week, they lose weight. Second week, they come to normal and the mother will say no weight gain. So again, a problem. Okay.
So any
You are
other
right.
points?
Absolutely right.
Sleeping properly.
Sleeping properly. Yes, sir. Nowadays, sleeping much more. So is it better? So take a note. We are just
Active
trying to
feeling
see
well.
how we can go on thinking. Okay.
So activity, feeding well.
And therefore, the only way you know the child is not sick is the child is happy, active, energetic. Same thing about all of us. Okay.
We also have something like gastrocolic reflex. So you can ask the mother, like if the baby is passing stools immediately after breastfeeding, then she should consider it normal.
Absolutely. So the gastrocolic reflex may not be normal at every age. But yes, and in fact, the reason why they pass 20 stools is every time after feed and in between feed. You're right. But what is the bottom line? Happy, active, energetic baby. Personal history is fine. Sleeps well, feeds well, plays well, weight gain well, etc. Right?
So obviously somebody who's been absolutely well till yesterday, and we said change in the frequency and consistency. So then we call it a acute diarrhea, and then we'll go into what is that. Chronic, roughly 4 weeks is what is defined, but obviously you have to again look at how unwell the child is to decide whether it's chronic diarrhea, which you need to take action for, right?
I think what he meant was if breastfed baby is passing 10, 20 stools, and now suddenly the mother says, I'm happy now. It's only one stool a day. You need to look at why suddenly it changed. Has it changed just because of intestinal maturity over time, or has it changed suddenly? And if that is changed, that might mean there is something going astray. We just keep a thought of all such things. I'm sure that in our busy work, we often don't have time to think. The only way we can think in a short time is practice thinking. Then only we can be quick in thinking, right? Yeah.
And then, of course, we look at the stool, as we said, what is the type of stool, and try and classify it. So broadly, clinically, we would have those 3 types: watery, fatty, and exudative. So by exudative, we mean blood and mucus in stool. And then we'll try and compartmentalize what is the pathophysiology behind it, and from there the cause, right? Okay. So if it is watery, So what do you think? If it is watery, what are the possibilities? You said earlier that it could be secretory. Anything else if it is watery? Viral. So viral is always secretory. Rotaviral is secretory. Then, okay, hyperperistalsis. So hyperperistalsis would give literal semi-loose to watery, but not frank water, tap water. So now this is also important. The moment you see a child who's having 7-8 stools a day, but 8 stools, stool matter mixed with some watery substance, then there is an element of motility problem here. That is what Murli was saying. Then anything else? So osmotic diarrheas are also watery, right? So broadly, if it is watery, clinically you are thinking of secretory or osmotic. Within that, what could be the various reasons? Viral infection, commonest. Then medicines, okay. Okay, cholera, very good. Then what else? Okay, so we have a host of causes, right? Yeah, diet, absolutely. So the moment we say osmotic, it means that something is not being absorbed, which is acting as a substrate, which is leading to the osmosis and the diarrhea. So whether that is a sugar, whether that is anything else, but something is not getting absorbed. So that is dietary. And how do you further identify it? By the presence of flatulence, anal excoriation, which will tell you that there is some sugar which is not being absorbed. Okay. Further secretory, we already said, is infection like a viral infection. It could be bile acid malabsorption. It could be tumors. It could be cholera. Okay. All these are causes of secretory. Other malignancies with secondaries, lymphoma, they can all lead to a secretory diarrhea. And we already discussed that hypermotility or hyperthyroidism will give you frequent motions, not absolutely watery, but not well formed also.
So I think this is just to make us think that there are multiple reasons why we see a child with diarrhea. Okay. And depending on watery to semi-solid, frequency may vary, the consistency may vary. And I recall a child who was presenting like a severe diarrhea several times, getting dehydrated, cholera negative, and it turned out to be a VIPoma. Very difficult to make out. Hyperthyroidism can come with diarrhea only. Of course, there are many other clues around, but the first symptom could be diarrhea, and subsequently hidden symptoms may come up, or the hidden signs may come up. This is just to revise that many times, for example, the magnesium, etc., we are talking about, people take antacids, and antacids could be the cause of diarrhea. Okay. So we need to look at how each of these problems could really cause a secretory diarrhea.
Okay. Suppose it is fatty. The look of the stool is greasy, fatty. Then what are your thoughts? What could be the reason behind it? Fatty malabsorption, which is possibly due to pancreatic problems. Then any other?
Large, infrequent, one or two, large, grayish white, foul smelling. What's the possibility?
Giardiasis.
Giardiasis.
Very good.
Okay.
Okay, so we look at fatty malabsorption. So it could be in cystic fibrosis, pancreatic or biliary disorder, as you all said, and giardiasis, right? And lastly, we have the exudative, which is blood and mucus. So the classic cause is bacillary dysentery. And then beyond that, suppose it is happening too often, what all you start? Crohn's disease, inflammatory bowel disease, colitis, etc., right? Okay. So that is our clinical approach. We will look at the type of stool and take it backwards to the anatomy, right? Okay. Now, which of the following statement is wrong? Once again, physical examination in diarrhea needs evaluation of this system. So the question is, which of these is wrong? So which system you don't need to evaluate? First is endocrine, second is respiratory, third is renal, or none of the above. And your voting time starts now.
Diarrhea can be caused by any systemic agent. We cannot negate example of any system.
Excellent. Pass. Even skin disorders will occur with the
Okay. So we can see from the voting pattern that some people feel that either endocrine need not be examined or respiratory need not be examined. So can you all justify why endocrine needs to be examined?
Yes.
Hyperthyroidism. Okay. Any other examples?
Me and
Sorry? Neuroendocrine tumors. Excellent. What about respiratory? Cystic fibrosis. Anything else? Any other connection of diarrhea with respiratory? Acidosis. So marked dehydration and hypovolumic shock and acidosis. Fantastic. And renal?
Can renal problem cause diarrhea?
UTI. How will UTI cause
Excellent.
diarrhea? You are right. So that's called parenteral diarrhea.
Parenteral
Fantastic. Yeah.
Okay.
Yeah.
So the
Okay.
point is, when you see a child of diarrhea, I'm sure parents expect you to put your finger on the tummy. Okay. What do you make out? You can look at the dehydration, sickness, etc. What do you make out by examination of abdomen? Nothing.
Abdominal
You-
tenderness.
Tenderness.
Thing that we can, floating could be. Hyperperistalsis.
Hyperperistalsis. Okay. Yeah. Pain tenderness. Yeah.
When a child of diarrhea comes with a distended abdomen, you are worried. If he comes with a sunken abdomen, you are not much worried. Okay. Why is distension to be worried about? Flatulence.
Interception.
Intussusception.
Alias.
Paralytic ileus.
Okay. It could be a beginning of an intussusception. He's waiting to vomit. He has got already a distension of abdomen. It could be sepsis. So again, distension of abdomen is a bad thing in a diarrhea. Okay. We just wanted to revise everything. We rarely would look at so how will you know that it's an acute UTI in an infant which is presenting with parenteral diarrhea? All that he has is fever and diarrhea. Okay. How would you know it's a parenteral diarrhea?
So, for example, yeah. Okay, dysuria may be there in an older child and in a lower UTI.
Sick child.
Excessive crying irritability.
So what we mean is, imagine there are two babies, both have fever and loose motions. One of them has a primary GI infection and one of them has a UTI.
Rajesh,
What will be the difference between the two?
Sicker child.
Okay, sicker child. Okay, frequent small urination. Anything else? Any other thoughts? So what is the sequence of events in somebody who has a primary GI infection and starts with fever? How long does that fever last? 1 or 2 days. And then what happens to the diarrhea? It continues. What will happen in a UTI child? Fever will continue and diarrhea may be just 1 or 2 or 3, right?
And a bacillary dysentery may start with watery stool on first day. Okay. But the high fever and sickness bothers you. And therefore, when you have a high fever and sick child, you know it's a bacterial infection. If it's an infant, more so on breastfeeding. Okay. In hygienic families, you start wondering why bacillary dysentery. Bacillary dysentery is not common in an infant unless you really totally miss out the hygiene. Even in the poor hygiene situation, it's not common. Then you start thinking whether it's going to be a parenteral diarrhea. And of course, parenteral diarrhea may not be UTI alone, could be mastitis, meningitis, pneumonia, anything. So the point again is we need to be very careful about not missing a parenteral diarrhea, right?
So I think now we'll start with cases and we will try and apply all this revision of basics, right? Okay. So there's a 2-year-old child who presented with mild fever and vomiting for a day. That settled, followed by watery stool 7 to 8 times. It was considered acute viral infection treated with ORS and zinc. Now, so far, any issues, any comments, any thoughts?
We all agree it's a viral infection, right? So we all agree.
Okay.
Let's see.
Now, diarrhea continued for the next 10 days. What is your action? So first is stool microscopy and culture option. Second option is start antibiotic. Third option is both of the above. Fourth option is none of the above. And your voting time starts now. So does anyone from the outside centers want to justify why stool microscopy and culture? Are they connected? Can you speak? Any of the outside centers wants to take that up? Why stool microscopy and culture? You could be right. There could be a logic behind it, but tell us why. Okay. Anyone here wants to comment on why stool microscopy and culture? Or you want to say that it's not going to be useful?
Viral diarrheas would take time for resolution. So just wait and watch.
Okay. So what will you do before you decide that you will wait and watch in this child?
Clinical recovery of the child. If the
In terms of?
if the stool frequency consistency is coming down, probably I'd reassure the relatives. And the general, they will be a relatively non-sicker children.
Very good. So if the child continues to be non-sick, is eating well, is drinking well, is passing urine well, there is nothing else wrong except the fact that the frequency of motions continues to be 10 times or whatever, 8 times a day, then you would just wait.
Anyone who has done stool culture in life, if not, then stool culture is not the test. But we will decide that when we come to investigation whether stool culture may be rarely required. But if none of us collectively have done stool culture, okay, then possibly we don't do even urine culture. What stool culture, isn't it? And do you do a midstream sample in a stool culture? Okay, so there are lots of problems. Let's see that.
Fine. So here it is very clear that just persistence of diarrhea is not the issue. You would look at many other things to decide your action.
I think what was said by her is malnourishing diarrhea, which is persistent, is a worry. Happy, active child. But why does it persist then? All viral infections should settle down quickly, no? There must be an immune deficiency, right?
The gut lining which is destroyed would take some time.
Absolutely. Not everybody repairs everything in the same time, no? But the fact that he is happy, ready to feed, tells you that the repairing process is on. Wait for a while. Okay, so again, a good thought. We would not have worried about it.
So what are the other errors which would lead to persistence, which we pediatricians should guard against? Okay, lactose intolerance. Anything else? Yeah, errors.
Hyperosmolar feeds is something like ORSL or some other electro.
Okay, so use of antibiotic, use of hyperosmolar liquids, not feeding the child, withholding food. These are all other practices which might in fact prolong the diarrhea, right? Okay. Let's come to the next case. A 2-year-old child presented with high fever, watery stools 3-4 times, and irritability for a day, followed by a generalized seizure. And on physical examination, the child is febrile, drowsy, but there's no dehydration. Okay. Now, what is the diagnosis? Acute viral encephalitis, acute bacterial meningitis, simple febrile seizure, or none of the above. And your voting time starts now. Okay, anybody here wants to take up simple febrile seizure and either defend it or argue against it?
It can be first episode of a febrile seizure. We have to ask the family history and other details. And the second possibility, it can be toxin, for example, Shiga toxin, which is giving rise to seizure.
Okay, excellent. So you're not convinced it's viral encephalitis. Tell us why.
Child is drowsy on examination because simple febrile convulsions, they will be, after convulsions, they will be awakened, all right.
Okay, so he's saying that simple febrile should quickly bounce back to normal. Here, this child is drowsy. And he gave us a very good example of a Shiga toxin causing a toxic encephalopathy. So anybody for viral encephalitis? Yes or no? Okay.
It could be viral with the parenteral diarrhea.
Okay. Okay. So we'll discuss what is not fitting into that. Anyone from the outside centers wants to interact on any of the causes?
एक बार दीजिए जरा स्पीकर अपना माइक दो
इससे होगा कनेक्ट होगा
ये दोनों माइक से कनेक्ट कराओ.
I think someone from Gorakhpur wants to speak.
Hello.
Yes, sir.
Myself, Dr. D.K. Bhagwani from Gorakhpur.
Yes, sir.
As per the given case, I will like to say the option should be B, because you have mentioned in physical examination, child is febrile, so infection is there, it's drowsy, and there is no dehydration. So once a child is drowsy, I will keep the possibility of meningitis first and encephalitis later. Because in encephalitis, I will see a fever, a convulsion, and loss of consciousness. And in a 2-year child, more history or more examination is required. But in given scenario, my first option will be B, acute bacterial meningitis.
Okay. Thank you, sir. Thank you for interacting. We will just, sir will now tell you what are the small things to look at which will differentiate. We did put options which look very closely similar on first glance. But now what are the finer differences, sir will explain.
I think we have said that this child had fever, diarrhea for a day and thereafter a seizure. So it's getting a little delayed for a simple febrile seizure. That's number one. You have almost not seen a simple febrile seizure in any febrile child with any other symptom. Okay. In fact, at one time, a simple febrile seizure was considered to be only due to viral infection. Okay, generalized viral infection. You rarely have a UTI with simple febrile seizure. You rarely have a GI infection with simple febrile seizure. Most of the simple febrile seizures are without any other symptom except fever and coming in for 12-24 hours. Okay, we say 24 hours, but often 12-24 hours or even before that. What about bacterial meningitis? Could it be a parental diarrhea? Okay, if you look at 2-year-old, he's getting less chances of a parental diarrhea, more often in an infant, a young infant. So that's number one. Second is, vomiting is a important symptom in an intracranial infection. Okay. And to that extent, one may not consider it to be so. Again, coming close in 24 hours period, a typical bacterial meningitis starts with a bacteremia, and therefore a fever, then irritability follows, a vomiting comes first, and thereafter the whole story gets worse. Older the child, it takes time for any intracranial problem like a seizure to come up. Seizure in a bacterial meningitis is very early in a neonate or a very young infant. But as the age advances, seizure is a later manifestation of meningitis. Okay, because the encephalon is not involved directly. Okay, and therefore unlikely. Why not a viral encephalitis? The typical viral encephalitis is a neurotropic virus. Okay, it starts as an encephalitis. You have a fever, and within 12-24 hours, there is drowsiness, unconsciousness, convulsions, and no quick recovery usually. So, to that extent, the answer would be none of the above. And he said rightly, it could be toxic. What is he trying to teach us? Something that happens suddenly and does not progress is likely to be immunological, metabolic, or toxic. Okay. And therefore, he came straight on to say that it must be a Shigella toxic. And it's not rare that a Shigella dysentery may start with a seizure and end up next day with a blood and mucus. Okay. These are the real cases. And I'm sure each one of us may have seen once in a while. We are discussing at a little uncommon level because we want to learn where we could easily miss out. And I'm sure that everybody will know that.
Somebody wanted to interact from outside. Bhopal, I think, wanted to interact.
Hello. Can you hear me, Dr. Chokhani?
Yes, sir. Please.
I am Dr. Vineet Jain from Delhi.
Yes, sir. Yes, sir.
Just wanted to make one more comment.
Yes, sir.
In acute bacterial meningitis, the seizure is not the presenting feature mostly.
Absolutely, sir. That's what Amdekar sir just explained. Yeah, absolutely.
And secondly, to rule out, we have seen cases of viral encephalitis where the drowsiness, onset is very gradual. Initially, child is conscious, a bit drowsy, and then goes into coma or anything. So that cannot be 100% ruled out in such a scenario. Only time will tell, and in retrospect, we can make a diagnosis. Although
Agreed, sir.
Seizure is unlikely.
Agreed. Perfect, sir.
Although
thank you.
even simple febrile seizure, even after 24 hours, we have seen convulsions, and it turned out to be simple febrile.
Yeah, those are there, sir. But what Amdekar sir meant is that majority of the ones which we see happen within a few hours of the fever.
Quite
so
right.
That's what we said. Yeah, absolutely right, sir. Bhopal wanted to interact.
Sir, good morning, sir. I am Dr. Chandramohan Reddy. Hello.
Good morning. Yeah, please go
sir, by history, it fits in acute viral encephalitis because it is a short duration. In within 1 day, the baby has child has developed general seizures.
So, sir, we just made a small point that in a viral encephalitis, once the child gets into a seizure, then they may not come back to normal sensorium. They will continue to be unconscious or whatever. So, but of course, there's a point made that it's a very short history, 24 hours. So you would see the follow-up also, right? Okay. Let's move on to the next.
And I think you would not be wrong if you did a CSF. Okay. Don't believe in your clinical judgment.
Yes.
Because you will do a CSF, but you will not be surprised if CSF was normal. That is what it is. And then the next day you get a blood and mucus, so you know everything is going right. Right.
Thank you everyone for interacting.
Okay, thank you.
They will get repeated seizures.
Absolutely. That's the point. So all of us are making the same point that a little bit of further progress of this child would perfectly seal the thing one way or the other, right? Okay. Let's go to the next case. So a 15-year-old child presented with watery stools for 2 days, considered.
Hello, sir. I am from Calcutta, Dr. M.K. Biswas.
Yes, sir.
I like to add something regarding
Yes,
this.
sir.
Okay. If there is sodium imbalance, that is
Yes,
the
sir.
main part of confusion and seizure. One. Second, iatrogenic. Rapid correction of the dehydration. Somebody is doing that without assessing the type of dehydration. If you correct rapidly, that can cause confusion and convulsion. Third, hyponatremic saline, profusely, if it is given profusely, that is important. And keep a watch regarding the sodium imbalance, serum sodium level, that is important.
Perfect,
And correction dehydration should be adjusted in nicely. That
Yes,
can
sir.
cause
Yes, sir.
confusion. Yes.
Absolutely. So, sir has revised the therapeutic errors for all of us. Very good. Now, let's move on to the next child. So, 15-year-old child presented with watery stools for 2 days, considered acute viral infection, treated with ORS and zinc. Any thoughts so far? Anything that looks a little different here? Okay, no fever. Anything else? Age, very good. So 15-year-old. So you just make a small note of that, but possible still. Okay. Now diarrhea continued with flatulence. Past history of epigastric pain off and on being treated with drugs and change in diet. Okay. Physical examination shows anal excoriation. And what's your probable diagnosis? So first option is rotaviral diarrhea. B is functional disorder. C is irritable bowel syndrome, and D is lactose intolerance. And your time for voting starts now.
अरे 15 वर्ष का हलचा है फंक्शनल डिसऑर्डर होगा APR लॉस में इरिटेबल या ऐसे करना ना बैक टू लेट्स गो मास्टर इतनी सुमा होता है 15 साल वाले आते हैं
Okay, so the largely everybody is divided between lactose intolerance and irritable bowel. Anybody here wants to take up anyone and argue for or against? Why lactose intolerance or why irritable bowel?
Lactose intolerance, primary, there won't be because 15 years old. Even secondary also, it can't be that.
So you feel it's more irritable bowel syndrome. Okay. Any other input? Yes, sir.
Sir, irritable bowel syndrome. Patient has got epigastric pain. I mean, that is one of the very classical criteria when you get when abdominal pain, either epigastric or a central abdomen, that is periumbilical is there, together with flatulence. All right. And if we go and drugs and change in diet has been happening, lactose intolerance is a very, very rare diagnosis. I would not think about it first. So irritable bowel syndrome criteria is also fit, more likely, and an elder child, 15-year-old. I'm at the moment treating one, irritable bowel syndrome.
I think irritable bowel syndrome is a syndrome where there is no diagnostic criteria, but yes, generally, at least 2-3 times a week over 2-3 months period, but not necessarily epigastric pain.
Not necessarily epigastric
generalized
pain. Generalized abdominal pain. Yes.
Okay, that is number one.
Sir, okay. Sorry to differ. There are laid down criteria. There are Rome criteria.
Yes, yes.
Rome 3, Rome 4 criteria.
Yes.
But in spite of all these criteria, none of the patients fit into exactly any criteria.
Absolutely.
That is my experience.
Absolutely. I mean, it was said 120 years ago that medicine is a science of probability. Okay. But we should not start saying that anything is possible. Okay. When I ask you, how are you? Sir, just now I am all right, but you never know next moment anything is possible. No, I am all right. Correct? So we go by probabilities. What is little difference here is epigastric pain.
That is
That is one.
Bowel syndrome, there
Dr.
is
Chugani?
alternating constipation with diarrhea, and that history is not eliciting.
Absolutely. I mean, there could be so many variables in all such things. But what is important here is epigastric pain, and second is anal excoriation.
Yes, yes.
Anal excoriation means there is some carbohydrate problem coming up. Okay. And then he has an epigastric pain. So what he must be taking? Antacids. Okay. And he must have had a change of diet. What change of diet? Start taking more milk. It is a natural antacid. When most of us don't drink too much of milk and we suddenly start taking milk because of our hyperacidity, we will start with diarrhea. And we're just trying to give cases which I've seen. These are live cases that I've seen. I may have missed it. I must have also called it an irritable bowel. Then I started thinking, where did I miss a point? Okay. This is just to kind of stimulate our thinking. What he said is absolutely right, that each one of us must have seen something unusual in a very common conditions. But even then, that is unusual, so commonness still remains. That is the point. So I think points are well taken. In fact, this is just to sensitize us to differ with each other. And everybody feels, yes, that is also a point. He made a point for us to think, yes, he is also right. Who is right or wrong is not important really. Best thing what is right finally, right? So good. He said rightly, secondary lactose intolerance is not common. It should not be considered in children at all, and primary is so rare. But when adults start taking milk when they are not used to, the first symptom is really all that. That is what all that why we wanted to, and that's why we put 15-year-old. Okay.
Okay. Let's move on to the next case. This is a 5-month-old healthy infant on bottle feeding, presented with large, frequent watery stools, followed within 2 hours with drowsiness, and was hospitalized in a state of shock. Cholera was ruled out by urgent hanging drop preparation. What are your thoughts, or what is your probable diagnosis of these options? So severe rotaviral infection, meningitis with parenteral diarrhea, any of the above or none of the above, and your voting time starts now. Okay. Anyone here for a severe rotaviral diarrhea? So then justify it. If anyone is against that, tell us why you are against that. Any thoughts?
Bottle feeding is a very common cause of infection.
Okay. Bottle feeding is a cause of infection. What else? You said age. So age is what? For or against?
For rotaviral.
Okay, for rotaviral. Is the course fitting in with a rotaviral? So this child starts with large, frequent, watery stools and in 2 hours becomes hypovolumic shock. Is that fitting in with rotaviral?
Okay, all of us must have seen rotaviral diarrhea. Okay, many of them are self-limiting. Occasionally, they may need hospitalization. Okay, just to give enough fluids. But rarely one has seen in 2 hours. This is a real case. It started in the morning, 8 o'clock, 10 o'clock, the child was in shock in 2 hours. Okay, almost like cholera, what it does. So while rotavirus may be a possible infection, the progress of within 2 hours coming in shock looks unusual. That is the point. So could it be meningitis really with parental diarrhea? No. Again, that should have thrown up a seizure first.
Within 2 hours, it can't be.
So that is not. Okay. Then what is it? This
So
is a real case.
can we analyze the 2-3 bits? So what does that large frequent watery stools mean? What did we say? What does it mean? Secretory diarrhea, right? So we have to look for some stimulus which is causing secretion. When we say bottle feeding, what is the first thing that comes to our mind? Infection.
So this is a child with infection. Whatever infection, viral, bacterial, forget about it. Which infection can go so fast within 2 hours to get into shock?
Some toxin.
Toxin, okay. Healthy child on bottle feeding. Are we looking at? Even that becomes very early, coming in shock. He could have thrown up a seizure like what we saw earlier, right? So the point that I'm making is, in medicine, whatever happens unusually, it could be unusual progression, unusual response, okay, is likely to be an immune deficiency. Okay, that is the point. And at 5 months, what immune deficiency comes in?
Which are the immunodeficiencies that will present in the first 6 months?
So the B cell, the maternal antibodies protect for first 3, 4, 5 months. And then when the maternal antibodies,
T cell mediated immunity will be in initial 5 to 6 months and B cell will be later.
Yeah, but within those 5-6 months, T cell will come even a little earlier.
T cell usually earlier. Okay. And this exactly coincides with maternal antibodies passively transferred, disappearing, and the child is not able to bring up his own antibodies. And this was typically a B cell thing. Point is, when such a fast progress comes up, how do you pick up an immune deficiency? Anything happening unusually, unusual progression into a shock in 2 hours. This was typically a B cell deficiency again on that. Yeah.
So I think we may not see another same diarrhea case in the next few years, but the thought process, like all of us picked up, that okay, does it look like infection? It is secretory. So what is the stimulus which is causing the secretion? That thought process is important. And then whatever 4 or 5 differentials, you shortlist
Again, the
those.
point is, whenever we have done occasionally for GPs, family physician, we don't show such cases. And we have to be a bit more than them. Okay. That is why we are picking up cases which are not common, but which are not unheard of or unknown. They are real, right? And that is why exactly this.
Okay. Immunodeficiency. A 8-month-old child presented with loose stools off and on for the last 2 months. Watery to semi-solid, greenish, no fever, but occasional vomiting, irritable, appetite good. On physical examination, the child was irritable with gaseous abdominal distension and the weight was poor for 8 months. What is the diagnosis? Chronic viral infection, chronic bacterial infection, chronic parasitic infection, or none of the above. And your voting time starts now. Okay, does any of the outside centers want to interact on this? The maximum votes were for chronic parasitic infection. Does any of the outside centers have an opinion on that? Okay, Gorakhpur. Yes, sir, from Gorakhpur. Unmute करिए गोरखपुर को. Yes, sir. Please speak from Gorakhpur. From Gorakhpur.
From Gorakhpur, yes, sir. None of the above is correct in my opinion.
Yes, sir. Why do you say so?
Because, sir, in age group of 6 to 8 months, we usually say that whenever we introduce supplementary foods, so such type of stools are quite common. Especially if baby is gaining weight normally and no other abnormal symptoms other than few frequent loose stools. So these are quite common. Even without infection, this is possible.
So you've made important points, sir. Only thing is here the weight of the baby is not good. But you've made important points that this could be without infection as well. But the weight is not good. Anyone here wants to pitch in?
Lactose intolerance is something we should consider in this child.
Okay, lactose intolerance.
Things are going on for 2 months. So bacterial infection and this thing, I mean, no fever and this thing that is out. Parasitic, the type of stool consistency is not matching. Viral, I mean, doesn't go off on for so time. So
Good, sir.
Maybe related to
Give
the
us 2 minutes, sir. Let the local person speak, then we'll come to you.
maybe related to the weaning food started. Some if wheat was added, something related to that. The poor weight.
Very good point made that 8-month-old child and it started 2 months back. So whether it started with weaning and it's related to weaning. Yes, sir. Online, please come in, sir.
Again from Delhi.
Yes, sir.
We wanted to bring out the same point. Since it started with the weaning period and carbohydrates are added, wheat is added, we have to think of transglutaminase.
Absolutely, sir. Absolutely. Well picked up, sir. So that's a thought process.
So good thought. New food introduced. What must be the new food?
Sir, wheat, they are saying. Wheat.
Carbohydrates.
Celiac, right?
Yeah.
But now take a note. What is bothering you in the first paragraph? Appetite good. Which is the disease with a good appetite? Okay, 2 months story. 2 months old.
Yeah, I heard something. Malabsorption. But which type of malabsorption?
Malabsorption. Now greenish stool. Malabsorption with greenish stool.
Giardia?
No, not Giardia. Yeah, but celiac disease is an inflammatory state. So usually appetite may not be good. Appetite is affected.
So what does greenish stool mean? There is a bile going out. The bile is irritant to the intestinal mucosa. So he is getting diarrhea because of excess of bile in the intestine. And why is the excess of bile? The nature doesn't produce more bile. So the bile that is
Underfeeding.
normally
Sir,
produced
underfeeding.
is not used. So he is an underfeeding child. Okay, one of the common causes of greenish stool at that age is underfeeding. He has got a poor weight and he has got a good appetite. In fact, he is craving for more. This was just a child who required some advice on nutrition and the diarrhea would stop, right? So something that might frequent. Okay. Not that every time I picked up this right, I must have made mistakes. And then I share with you how retrospectively I feel I should not make the same mistake. Of course, in life, you can make so many new mistakes that you don't have to repeat the same mistake, right? So we'll keep on doing mistakes. but we will learn from them. That is the whole idea.
So once again, very good interaction from everyone, and we started thinking that it need not always be infection. We picked up the age at which it started and what could have gone wrong at that age, and that 2-3 possibilities, and which of those. Very good. Next, move to the next case. 10-year-old child presented with loose stool 3 to 4 times a day, semi-solid with mucus, occasional blood, and fever off and on for the last 2 months. There is loss of appetite and weight. On physical examination, the child looks chronically sick, has gaseous abdominal distension, and a mild generalized tenderness. What is our probable diagnosis? So first option is intestinal tuberculosis. Second option is chronic amoebiasis. Third option is celiac disease. And fourth option is Crohn's disease. And your voting time starts now. Okay. Anyone wants to take up the options and discuss for or against any of the options? So anybody wants to argue against amoebiasis or against tuberculosis or for tuberculosis? Any thoughts? Or we can start analyzing the story as it is presented to us. Okay, so how many times have we seen amoebiasis in pediatrics? Are we seeing it commonly? Not really, right? So chronic amoebiasis will keep aside. What about celiac disease? We just discussed celiac disease.
It will be there. After taking wheat and
Okay, so there may be abdominal pain after taking wheat. Anything else? Fever won't be there in celiac disease. Okay, anything else? Whatever, sir, just interaction. So we are learning. Okay, sir, the mic.
Sir, intestinal tuberculosis fits maximally into the picture, I feel. Loose stools, fever, occasional blood, fever on and off, abdominal distension, chronically sick for such a long period, fever for such a long period. So it is more likely to be tuberculosis. Celiac disease is out, chronic amoebiasis is not in this age. Crohn's disease will not present so early and in this fashion. Somehow feeling it's tuberculosis.
Okay, anybody from the online audience wants to pitch in? Anybody, Hyderabad, anybody wants to pitch in? Okay, fine. I think sir will sum up.
This is one example where we even break down anatomical diagnosis to a microscopic level. Okay, most of the diarrheal disorders are mucosal. Where is the microanatomy of the intestinal tuberculosis? It is submucosal. And therefore, the presentation typically is alternating constipation and diarrhea, more constipation as a result of an intestinal obstruction and a recurrent intestinal obstruction with an occasional diarrhea coming up in between. And therefore, as a rule, intestinal tuberculosis, not being a mucosal disorder, does not present with diarrhea alone. Even when the story looks like low-grade fever off and on, etc., everything looks alike, but it is a submucosal illness, and therefore, as the time goes, it presents as a subacute intestinal obstruction. And many obstructed stools may also have an overloading, causing a little diarrhea too. And many times the constipation may come with a little leakage of watery stools. And if we don't get into details, we have missed a constipation. So intestinal tuberculosis, therefore, is not likely. Already I said chronic amoebiasis. Typical celiac is an inflammatory disorder. So any kind of stool is likely to be there. But fever is unusual because it's a localized inflammation. Fever is a generalized or a severe inflammation, and therefore unlikely, and therefore mostly it fits in a Crohn's in this child, right? But after all, I've seen a child who looked typically with Crohn's, had come from out of India, and then I said, you confirm with an endoscopy. Okay. And the biopsy showed tuberculosis. Okay. Our basic concept, TB doesn't come with loose stools, which is what I learned from our pediatric gastroenterologist only. But the histopathologist said TB. So they started with anti-TB treatment with steroids, and within a week or two, he started getting better. He went back, came back after steroids were withdrawn with the same story. Another endoscopy done, oh, typical of Crohn's. I asked the GI specialist whether Crohn's and TB look alike, but can both be together. So the point is, TB and Crohn's, or like a TB and a non-Hodgkin's or a Hodgkin's lymphoma, may look alike even to a histopathologist. And as many times we are not sure of what we are saying, they are also not sure of what they are saying. They also go by probability, but we see a type report and we start believing in them, right? So this really is typically a Crohn's, but diagnosis is not easy, even to a gastroenterologist, to a histopathologist. Then what do we depend on? We depend on the basics. If we saw 10 children on either side, only one of intestinal TB may have a diarrhea, but 9 will not have. So we will call all of them as no TB. Exceptions always are there, right?
Sir, a small point, sir. You spoke about diarrhea and intestinal tuberculosis, or rather alternating, constipation with loose stools. Sir, such typical pictures may not be there. I'll give you the reason. Number one, which is the location of tuberculosis in the gut, plays a big role in what is the presentation of stools. If we are talking about right-sided, that is ileocecal tuberculosis, you may not get the the constipation picture at all, because those are more of ulcerative lesions in intestinal tuberculosis. So here, the typical picture is abdominal pain, which you will be getting, and diarrhea may be there, but alternating. And the obstructive symptoms of tuberculosis typically are seen onset after initiation of treatment, because then when the fibrotic process sets in, so we get more of an obstructive picture later on. That is what is more commonly seen, rather than when the patient is not on any treatment. So this is somewhere, and ultimately these are all ulcers. So as an ulcer, diarrhea will be more common than what we have is constipation, as you rightly said. So alternating somehow the picture, I was not very convinced, sir.
I have never seen what you are talking. My pediatric gastroenterologist convinced me what I have said is right. And the reason is, the focus is submucosal. To develop a mucosal ulcer, it is spreading from submucosa to mucosa. That is the difference. Mucosal ulcers are not primary mucosal ulcers. It is coming from an extension of submucosal. It is also not acceptable to me. You may be right that it's not the treatment alone. The nature is also trying to heal the lesion. So even without treatment, in fact, I have seen more often a recurrent subacute intestinal obstruction as an intestinal TB.
Absolutely.
Not even in diarrhea.
Absolutely.
That is typical. Why? Because submucal focus has started recovering by nature.
Cicatrization.
And constructions have occurred. What you say must be right. As I said again and again, anything can happen, yes. We are not saying that now you start taking at all. You do endoscopy, you do biopsy. And as I gave you an example, even on biopsy and the GI people vary and they are proved to be wrong even after all that. So the question is, we are here discussing what is most likely, and we are also discussing that even the best of the investigatory report may also be wrong. It doesn't mean that we are right and they are always wrong. No. But all of us can be equally right and wrong. What is making a point every time is valid. We cannot go only by what we think. We should keep our eyes open. Okay, that is what would be right.
So I think it was very good that all of us picked up the chronic inflammation here. That is the first step.
Yeah.
And then, as ma'am rightly said, for celiac, fever was a odd point. So we removed one cause of chronic inflammation, and then we debated between the remaining possibilities. Coming to the next case, a 8-year-old child presented with abdominal pain and loose stools off and on for last 4 months. Loose stools at times with mucus, 2 to 3 per day, mild to moderate abdominal pain, no fever or vomiting, appetite is variable, and there is no loss of weight. And on physical examination, NAD. What does NAD stand for? Also for not actually done. Okay. So what's the diagnosis? So first option is tuberculosis. Second option is chronic parasitic infection. Third is inflammatory bowel disease. And fourth is none of the above. And your voting time starts now. Okay. So anyone here for none of the above? Anyone has voted for none of the above? What is the difference between this case and the previous case, which we just discussed? No fever. What else? No weight loss. What else? Appetite is variable, which means it's there. There's a reasonably good appetite at times not so good. So what do these 2-3 things tell you? No fever, no weight loss over a 4-month period. What does it tell you? So not a chronic infection like tuberculosis. What else? Not infection. Okay, very good. You will say this is not infection. What about inflammation? Do you think this is chronic inflammation? Fever, and again, for chronic inflammation, constitutional symptoms are important. Sometimes there may not be fever in chronic inflammation, but constitutionally loss of weight, loss
Sir,
of appetite.
loss of weight is not here.
Yeah.
So that goes against an inflammatory disease for such a long time.
Very good. Very good. Yeah. So
I think that is where we come out to say that none of the first 3 are possible. And when there is no loss of weight and the appetite is variable, but no loss of weight is an important thing, which means that there is no chronic progressive illness, neither inflammatory nor infective, at the most functional. But if it was a malabsorption, there would have been good appetite and losing weight. So it is not disturbing the function a great deal, but still there are symptoms. This is like your irritable bowel.
Exactly.
Okay, that's what he was trying to say that. Okay, this is the irritable bowel. Okay, only irritation, but irritation not doing anything.
Sir, what is the youngest age which you have encountered for an irritable bowel syndrome, sir?
So, irritable bowel syndrome is a diagnosis of exclusion. Largely. Okay. But what is peculiar is the disease is going on for a long time, but there is no big functional disturbance coming up. There is a symptom, there is a pain, but if you ask them, is the pain disturbing you? Probably not. Is an appetite disturbing? No. So to me, symptoms without functional disturbance in a routine activities is likely to be one of those. Now we really don't know the correct cause of irritable bowel. Okay.
After seeing so many, yesterday I saw a 14-year-old boy and seen by a pediatric gastroenterologist, endoscopy done, gastritis, H. pylori infection positive, given a course of amoxicillin and the H. pylori kit. Thereafter, because of amoxicillin, lot of diarrhea. So to control the diarrhea, other medications were given. Ultimately, happened to be my friend's son, so they brought to me. And after seeing and taking the detailed history and seeing him bend down in pain, I was very convinced I'm dealing with an irritable bowel syndrome because no relation to meals. Otherwise, patient is fine, occasionally gets the pain, crampy, gets relieved by burping, no diarrhea, nothing. So when nothing fits, as you rightly said, between symptoms and the findings, it is irritable bowel syndrome unless proved otherwise. And the only problem is you cannot prove it. But many a times I have taken the help of my psychiatric colleagues and it comes either as anxiety or depression.
Absolutely. I fully agree with you. The point that he made is if most of us are Manto positive, most of us have H. pylori also. And we have many endocrine and GI specialists, many endoscopists. So H. pylori is not a diagnosis at all. I think it comes in fashion. At one time, H. pylori came and a triple therapy came. Now it has disappeared to large extent, but an endoscopy still find H. pylori. And who doesn't find H. pylori? If you are abroad and if you miss your passport, ask them to do H. pylori endoscopy and a Manto. If both are positive, you are Indian. You must get a passport. It's that common. Okay, yeah.
Sir, just to add a small point, the endoscopist, I also followed the case with the histopathologist who proved that this was an H. pylori positive. And she tells me, because one sentence really intrigued me towards the end of the report, that there could be a possibility of Crohn's. I immediately called her, asked her to see the slides again. She says, I'm finding granulomas in the stomach, and which is extremely rare. I said, you are a histopathologist, you are seeing your slide. There is no reason for me to call this Crohn's just because some granulomas are seen in the stomach. You cannot change the entire course of the disease.
Absolutely. And histopathologists and radiologists do not know clinical story at all. We just say do biopsy. Okay. So I think points are well made. Let's get to the next one.
So we move on to the next case. A 6-month-old infant on bottle feeding presented with fever and loose stools for last 2 weeks, treated with 2 sets of antibiotics with a partial response, past history of GI infection. On physical examination, weight is 5 kg, length is 62 centimeters, irritable, sick, mild dehydration, gaseous abdominal distension, and stool examination has shown no abnormality. So what will be our action? Options are upgrade to parenteral antibiotic and put the child on IV fluids, that's nil by mouth. In addition, start antifungals and soya milk. Or third option is no antibiotic, only soya milk. And fourth option is no antibiotic and special diet. And your voting time starts now. Okay, very good. So I feel that even from this house, there will be somebody who belongs to either C or D. So give us your logic for either C or D. What is your thought process? What have you identified? What have you picked up? Any thoughts?
Child is not responding to the antibiotics if even if given in the past, so there's no point in adding another one, probably even the parental one. And the diet wise, there's there's no, I mean, mention, and the weight gain is also not perfect, so it is like in 6 months it's only 2.5. So probably, and it's a irritable child and who's a sick, so he needs some more investigations, obviously. Other than this. And once you come to the conclusion, only then we can decide whether it's an immunodeficiency or some other thing we have to rule out.
Maybe any other thoughts? So I think ma'am has excellently picked up that this child is just 5 kg at the end of 6 months, and that couldn't have happened with this 2-week diarrhea. The history is fever and loose stools for 2 weeks and 1 past history of GI infection. So that's not the cause. So there is something at the bottom of the whole thing. And therefore, the basic concept is that this diarrhea is not in a normal child. This diarrhea is in a malnourished child. That's one big basic concept. And therefore, our whole thought process will change.
And I think malnutrition with diarrhea is a complex problem, and you have malabsorptions of all kinds, not only lactose, but multiple. You have a bile acid irritation. You have an immune disturbance. For example, in a small baby, if there is an intestinal mucosal damage, the whole protein can get into it. And when whole protein gets into it, you have an immune responses. So you have immunological, metabolic, bile acid irritation. You have a malabsorption. Infections have been taken care of. So now you want a diet which can take care of digesting and absorbing largely protein, fat, carbohydrates, and taking away bile acid irritation if at all, and hoping that the immune system starts behaving normally once the mucosal recovery starts happening. Therefore, a special diet. Now, special diet, simple special diet is soy milk, no? What is wrong with soy milk? After all, cow's milk or animal milk can cause immune response. What about soya milk? That is much cheaper than elemental diet, right? So soya milk also is often the cause of problem. Okay, soya protein is also often the cause of problem. So you may try soya milk. If not, you need an partially or completely elemental diet, which means items which are already digested and made absorbable, ready-made kind of. Only such things may tide over the crisis. Once the crisis is over, the intestine mucosa is repaired, you can get back gradually to a safer kind of diet, which is largely complex starch, okay, no animal protein, okay, medium chain triglycerides, and then slowly go back to that. The whole idea of showing this is a complex problem, often would need a special diet. Okay, I think we just wanted to have just 8 cases. We will now, in the last 15-20 minutes, take some discussion on investigations and management, right?
Congenital infections also maybe something like HIV or something in this case.
Yeah. So why that child is malnourished, we need to find out. It could be primary dietary or a systemic disease underlying. Now, very superficially, if it is an underlying systemic disease, the disease would come with its own manifestations. Means the child wouldn't come today to us for diarrhea. So this is likely to be purely a nutritional problem who has now come with diarrhea to us. And therefore, but the focus was antibiotics or antifungals is not the solution. We need to look at the nutrition of the child, right?
In fact, 3 decades ago, a UNICEF chief who was in India made a statement that infant with acute diarrhea is a nutritional disease. And he said, bother more about nutrition than diarrhea, because diarrhea causes malnutrition and malnutrition causes diarrhea. And at one time when I was being trained 60 years ago, it was usual to say nil by mouth. Okay. And we realized how terrible we were wrong. Now it's the nutrition that is the major cause of diarrhea, right?
Okay.
Okay.
So now you
Okay,
can
sir.
give porous interactions also.
Sir.
So is stool routine microscopy useful in acute diarrhea?
Sir.
Any thoughts? Yes, no, maybe, sometimes.
Sir, I like to add something.
So not
Regarding
always,
this
most of them are viral in origin.
And
So
if they are bacillus dysentery, you know already.
Useful in cholera.
Okay, whether it goes
useful in
fungal-
cholera, okay. So in cholera, you would look for hanging drops specifically. So just a routine may miss it, yeah. Anything else? Any other comments? Okay.
Sir, one comment from our
Sorry?
end.
Yeah,
Okay, one
yeah,
comment
Kolkata, please
from,
come in.
From Calcutta. Okay. Regarding this patient.
Yes, sir, Kolkata, sir, please come in.
Okay, we do not have the
We
idea
can't hear.
what was the,
Yes.
so what
Yes,
was
now
the
we can hear,
bathroom
sir.
of the- Okay, listen. Okay. Sir, what was the bath toilet? That was not mentioned. Regarding diarrhea of 12 to 15 to 2 weeks, there is the diet of the child that can be modified. In our developing country, lot of modification of diet from parents, grandfather and co-workers, that the resting energy level, the diet was so poor, the child loses the weight. How can you tell a 6 years baby with 5 kg weight? Have you have the initial birth weight? No. Second, with the when the patient have diarrhea, did you have an inquiry regarding the diet? That usually modified from parents and cooks. Would you not know that? That you not show. You cannot tell this is a weight is below par, not so below par. Something should be there regarding diet. That is the important. Whether the
Yes, sir,
diet
that is exactly what we were telling everyone, that in a case of diarrhea, the diet is very important and we need to focus on that. Absolutely, sir. Thank you. Next investigation, what is your action if reducing substance in stool is detected in acute diarrhea? What is your action if reducing substance is detected?
Mostly diarrheas will be accompanied by a transient secondary lactose intolerance, and in that cases you will get a reducing substance positive. So that can only just define that there is a transient intolerance.
So in
So
short,
what is our action? What should we do?
Mostly nothing, or tell the child if he is overfed with the milk to just reduce it, not stop it.
So the point is never look for lactose in an acute diarrhea at all. What she said is so right. Exactly. And therefore we all know that it's only in a chronic diarrhea where you may presume that there is going to be a lactase problem, because the lactase is the most superficial enzyme in the mucosa. It's the first one to get better. Why waste time in testing it? So there is no question of testing routinely the reducing substance at all. Let's not reduce to that low level. Right? Fine.
What is the significance of yeast in a stool sample?
It's a fungus. You will get
contamination. It's a contamination.
It's a common cell as well. Okay. So we will not worry about that yeast.
So we won't treat them with antifungals. What is the significance of fat globules in a stool sample? Malabsorption, temporary or permanent, we don't know. So what do you do? What is action?
The diet has to be modified. So you don't give a lot of fat or milk, butter and all those things. You can change.
Any other thoughts?
We can give curd, we can give buttered milk, we can give And first of all, I want to add one thing, that why don't you stop the bottle first? The child is bottle fed 6 months. The cause of infection and this fever might
Sir,
be.
that is discussed. That is already discussed, sir. Yeah. No, this is in general, sir. That 6-month child with whose bottle fed is done. We have stopped the bottle. Okay, this is in general. We are saying that what is the significance of fat globules in any stool report or stool sample?
You will have to give less fat, more buttered milk or curd rather than milk. That's all.
Okay, sir. Okay. Okay.
So I think like lactose, some fat globule seen has no meaning at all. But if you are suspecting a fat malabsorption, and if you saw fat globules, it may be a good idea to do a fat challenge and show that there is a disproportionate excretion of fat. Okay, almost like a glucose tolerance test. You give a measured amount of fat in the diet and see what is the proportion that's coming out of a stool. But if you're not suspecting a fat malabsorption, ignore that. You don't have to worry about it at all.
What is the indication of a stool culture and how do you collect the stool sample?
We have already said, but how do you collect it? Suppose in a rare situation of a chronic malnourishing progressive diarrhea, infection may be also a concern. Okay. And we may consider stool culture. And if a stool culture shows something unusual, we will have to give a credence to that. Question is, how do you collect a stool sample? Difficult, right? Yes.
Can use a sterile green sheet or something, plastic green sheet.
So you have to have a sterile container in which you collect the poo. Okay. And if it's a solid stool, then take again a sterile container and take a sterile wooden spoon and pick up a sample. Difficult, right? Fortunately, not required also great.
Sir, a rectal swab?
Yeah, rectal swab is not a good idea because we are looking at an intestine. Okay. And on the rectum, it may not represent what is it. To that extent, a throat swab for a bronchial problem is not a good idea. Something similar. Okay. So the point is, that's why we have never done it. And it's good we have never done it. Okay. This is just to make a point.
So when it is done wrongly, when somebody asks for a stool culture and you get E. coli, that has no meaning because everybody has E. coli, right? So that has no meaning. When do you consider malabsorption studies? Obviously, when you are suspecting malabsorption, based on what? Chronic condition, growth is affected of the child, chronic diarrhea, and sorry, signs. So what signs?
On the skin, basically the hair texture.
Very good. So you look for clinical signs and you actually try to decide whether it is carbohydrate, fat or protein malabsorption if possible. So like we said, perianal excoriation, flatulence suggests carbohydrate, a greasy bulky stool would suggest fat, edema would suggest protein malabsorption, and then take it further.
And generally, the malabsorption, if it is non-inflammatory malabsorption, appetite is good. Whereas if it's an inflammatory, okay, like a protein-losing enteropathy is an inflammatory, then appetite is also down. So those things we are clear about and rightly said what you have said.
Is imaging necessary in diarrheal disorders?
Not always, sir.
So very uncommon, but what are those rare uncommon situations?
Colitis, Crohn's and also Scopy, I mean.
Scopy for diagnosing, yeah.
Stadium studies if it required for identifying any chronic ulcers or.
Okay.
These are going to be more so mucosal disease. So you'll not be able to identify on any known modality. Endoscopy is an invasive procedure. So, I mean, nothing is really going to help.
Yeah. Intussusception. Okay. Fine. Now we come to, yeah. Pune. Yeah, Pune, somebody wants to interact. Please come in. Pune.
Hello.
Yes, sir.
I am from Ranchi.
Yes, sir. Ranchi, sir.
Flat globules you shown in the stool examination. Why don't we think for giardiasis, which is very clinically significant disease, if the flat globules are present in the stool without any other condition related there?
Sir, the point we were trying to make is that isolated fat globules in a stool report may almost mean nothing. Now we have to correlate it with the clinical picture. So if we have a clinical picture of chronic malabsorption, then think of fat malabsorption and then take it further. So like you are saying, giardiasis again, we will have to look at the clinical picture and see whether it looks like giardiasis. Our emphasis only was to say that just fat globules in a stool report may mean literally nothing. That was our emphasis, sir. Thank you.
Thank you.
Pune wants to come in on anything or we move ahead? Okay. So now we come to another simple question. Drug of choice for symptomatic control of diarrhea is A. Loperamide, B. Resicadotril, C. any of the above, and D. none of the above. And your voting time starts now. So I think everyone is none of the above. So we are very happy to see that. Okay, good. Let's move on to the last.
Why not? Symptomatic relief for fever, very much. Symptomatic relief of cough, very much. Pharmacologist teaches there is no cough syrup worth. Even then, symptomatic relief. Okay, pain, symptomatic relief. Diarrhea, what you tell the parent, chalne do. One day it will get well. Why? We must use symptomatic relief. Don't you think symptom relief is important? We all agreed, no, let him pass those stools. How can it be?
Hello. Yes, I want one question.
Yes, sir. Online, yeah, please come in.
I am from Ranchi, Dr. P.K. Gupta.
Yes, sir.
Actually, the most of the patients these days diarrhea from the village, remote areas, and all the patients using the commercialized electrol powder. It is either concentrated or diluted one. So, is there any product we should introduce through the IAP for the ORS for the children?
Sir, all the WHO ORS that are available in the market, they are not concentrated or dilute. The problem sometimes, as we all know, is the parents reconstitute it wrongly and then they change the dilution. One of the common mistakes is to take 1 teaspoon of the powder from a packet and put it in X amount of water, and that could be either a dilute ORS or a concentrated ORS. So most of the WHO certified or WHO formula based ORS are good enough, sir.
Diarrhea, actually, everything is getting checked. Toxins, bacteria, the viruses. So let it go out. You try to stop it by giving loperamide, they might multiply inside and aggravate. Paralytic ileus might be also a complication if you try to stop the diarrhea.
See, the point is, like viral infection with fever, Fever is going to disappear in 3-4 days time without doing anything. We still want to give paracetamol because let him be comfortable in spite of symptoms. Okay, symptom may not be relieved, but the discomfort is relieved, no? Who wants to go 10 times to the loo? You say, no problem. Let you pass lot of water, we will give you lot of water. How can a patient accept that? Difficult, no? Yeah.
You have to do counseling. If urine output is good, and if you give ORS properly, and if you correct the dehydration, it will be okay. This ORS is like a placebo effect, like you are giving medicine for symptom. It will take time. Like cup syrup, you are saying, then also.
I think everybody scientifically is right, but as a patient, I would like
ORS
you
cannot be
to
placebo,
give me
right?
some relief.
But how ORS can be placebo, sir?
Yeah, sir, 1 minute. Sir, there's something online. Yeah, please come in online.
Hello.
Yes.
Sir, how?
Yeah, Kolkata, ma'am. Kolkata.
Sir, how ORS can be placebo?
No.
There is all rationale to give ORS. So we
No,
are not
it
giving
is-
ORS for placebo.
No, it was not meant in that sense of a placebo. So you're right. Yeah.
Sir, whatever you give, you are just giving for the satisfaction of the patient that I've been given something. So I think ORS supplementation is good enough. And this is sponsored by Vizelac. So Vizelac sachets if somebody wants to give, otherwise nothing, sir.
I think sir's question was, why are we not giving symptomatic treatment in diarrhea? So probably the answer is either the symptomatic treatment has complications, like all of you said, for loperamide, or they are ineffective is the other answer.
The point is, adult physicians use it regularly. Absolutely regularly. Okay. And why we pediatricians don't use it? The point is, younger children may have complications, especially if there is an infection, inflammation, you want to restrict. Why is there is a diarrhea? The nature wants something that is irritating to be passed out. And you are trying to withhold it. In adults, rarely it is major infection or so, and therefore traveler's diarrhea, some mild indigestion, all those drugs are safe. Our children don't run into those causes more often, and that's why we don't. Okay. And the answer is right, we don't. So we tell the parents, today the most common cause of diarrhea in children of acute is infection. We tell them that by stopping diarrhea, we are withholding the infection and the inflammatory discharges, not drained. Abscess has to be drained. Okay, here nature is draining. Tolerate for next 2 days, you will be better off. Counseling, yes. But patient want a relief, and you say relief not at the cost of complication, so bear with us. You are all right, but we just wanted to make sure what it is. Now, in the last 5-10 minutes, we'll discuss some management issues. Okay?
Sir, my one question, please. I am from Ranchi, Dr. Jagnani speaking. Government sir बोलती है कि नमक और चीनी का घोल पिलाना है डायरिया के केस में.
Yes, sir.
How do we justify this along with ORS? What is more right? Why don't the government withdraw this principle of putting namak chini ka ghol and putting unnecessary, unauthorized, disproportionate fluid to the diarrhea patient?
So, sir, you are absolutely right. Unfortunately, I am not the government, so I can't answer on behalf of government. But meanwhile, sir, just a point to note. So we all know the truth. You're right that a standard preparation of ORS is superior to homemade ORS. However, please note, sir, even in the city of Mumbai, in the government medical college, ORS is often in short supply. So that's the unfortunate, bitter truth of life. So once government makes ORS available everywhere, we will probably not use homemade ORS. But point is made, sir. Yeah, quick. Somebody was saying something here.
Sir said why in children it is more because water compartment in the children and adult is different. Water compartment is more in children as compared to adult. That's why anything related to diarrhea should be treated more aggressively in children rather than in adult. So we can give loperamide in adults, we cannot give in children.
So we need to get a correct judgment of the water loss is what sir is trying to say.
Absolutely.
And therefore absolutely right.
Absolutely right.
Yeah.
See, we do not want anti-motility drug. We may not mind anti-secretory drug. But the nature want to secrete more to drive away the thing. When you have a foreign particle in the eye must water. You say, stop watering the eye, then the particle will remain inside. So watering has a purpose, and therefore you are right that we don't want to falsely cause a control of frequency of loose stool at the cost of complications, and that is exactly what we have agreed. Now, probiotic, we will discuss, but at the end, with your permission, I will ask
Sridhar
to talk about probiotics because he's an expert in it. Okay, we have hearsay knowledge. Okay, but let's first discuss something.
So-
Acute viral diarrhea, you want to use? People are doubtful. We'll ask him later. Okay. Yeah. But probably no. Okay. Persistent loose stools after viral diarrhea. We saw a child who was having 10 days of loose stools. You will use it? You may try it. But he will answer all those correct things, right? You may try it. Okay. But like zinc in acute diarrhea is known to shorten the period of diarrhea, but what? Maybe 0.5 days, 1 day. I even don't know how they come to that, but that's a good idea because parents want a drug and you have a drug. So it serves the purpose. Acute bacillary dysentery? No. Okay. But he will answer all that finally. We depend, Sridhar, on you to answer this because he has studied probiotics in great details. Okay. And I would like his opinion. Inflammatory bowel, maybe some reports. See, whenever we don't know, we want to try everything. And if something is safe, we must try. Okay. It may work, may not work. You're not sure. But when we ourselves don't know how to treat, we must exploit every possibility. So probably inflammatory bowel, we might use. Irritable bowel, yes, again, multiple reasons. Okay, we don't know. All right. And functional abdominal pain, again, a problem. Now,
okay, so there is this concept of probiosis because when you look at the gut, it has a lot of microbiota, microbiome, and the number of organisms in our gut outnumber the number of cells, but not by a factor of 1:10 that has changed. So now we tend to use a term called dysbiosis. So we know this microbiome is contributory to health. They are needed for digestion, they are needed for immune regulation, they are needed for colonization, resistance, and a number of things. We still don't know much about it, but they are there with a purpose. So out of 10 things that you eat, almost 6 are digested with the help of your microbiota. So when we were talking about indigestion, so the microbiota does play a role. So that is why some people can tolerate onions, others can't. Okay. Now the thing is, we misuse the concept of probiosis. So it's just like if I should get used to the microorganism that I ingest because I've got my own enterotype. Just like you have blood groups, you have your enterotype or your microbiota. So if you put any microbe into your system, it's not going to work as a probiotic. Like the way we generalize probiotics, that's not going to be possible. The 3 main playmakers in the market today are Lactobacillus GG, you have Saccharomyces boulardii, and you have Bacillus clausii. Now, if you take world literature, Espegan, Naspegan, what you get to know is maximum studies. Today, we have a concept called as enterotype. That is, each individual has his own enterotype. So he may respond well to one, he may have an adverse reaction to another. So that is why you require evidence-based therapeutics. Evidence-based therapeutics means you have to treat a probiotic like a drug. You need to know the indications, the dosage, the interactions, and the side effect. Because you can use it for bioterrorism. They can translocate. So as you move from the small intestine to the large intestine, the mucus level goes on increase. Same way, the microbiome also goes on increase. So what happens is they don't translocate because of the mucus layer. But the unfortunate thing that we do is misuse metronidazole, which reduces the thickness of the mucus and allows translocation. For every abdominal pain, we prescribe without even trying to understand what causes the pain. So the indications that were given here and for probiotics, and if you take extrapolated data from Western literature, the two main bodies, Espegan and Naspegan, what they say is, if you take a viral diarrhea, low to moderate, it's supposed to be Lactobacillus GG, which rules the roost. If you take an antibiotic-associated diarrhea, naturally the fungus has a little upper hand over Lactobacillus GG because it's a fungus. It's not affected by antibiotic. And you need to start it right from day one. Okay. Then if you come to persistent loose stool, so when Dr. Chokani was talking about acute and chronic diarrhea, in olden days, we had acute, persistent, and chronic. So an acute would go into persistent when you develop the lactose intolerance. A chronic were all the syndromes like celiac and the rest. So in persistent diarrhea, yes, there is an entity called dysbiosis. That is, the flora is totally altered after an insult, be it a drug, be it your medication, be it an infection. So the numbers are altered, the type is altered. You have more of opportunistic pathogens, and there is a low-grade inflammation. And that is why malnourished children usually don't do well, because now there is an entity called environmental enteropathy. So the gut is so bad and it's in a low inflammatory state, you have to bring down the inflammatory tone to even improve nutrition. So supplementing also won't help. Even if you give hydrolyzed formula, a similar MCT, it's not going to help. Coming to acute bacillary dysentery, yes, a little bit on the side of Saccharomyces boulardii, especially for amoebiasis and giardiasis. But again, if you really see Lactobacillus GG and Saccharomyces there aren't enough studies on clausii, though in vitro study gives you a lot of things that will tell you that clausii can work in antibiotic-associated diarrhea in bringing down the number of days of viral diarrhea. But if you really extrapolate, there is not much of data. So that is why none of the big organizations mention anything about Bacillus clausii. If you come to inflammatory bowel disease, it is pouchitis. There is a definite role. So you have something called as BSL-3. They are a cocktail of probiotics, Lactobacillus and Bifido. And you can use Lactobacillus GG. Irritable bowel, again, what we do is when you talk of functional GI disorders, because of the pain, and you have the constipation and the diarrheal variety, you have different sets. Ruteri is something which is used left, right, and center. GG also has a role there. And so does Saccharomyces boulardii. And any other non-GI indications? Yes, today for almost every possible thing, we are using probiotics. So even for the skin, atopic dermatitis, we are using a bacterial culture, because we know that the staph and the roseomonas, which are altered, are the ones that are responsible for it. So this is a science which is upcoming. Lot of hope, but a lot of hype also.
Thank you, Sridhar. Thank you so
very
much.
Thank you.
Top 3 probiotics, because I have attended one international conference. Nowadays they are saying ki Bacillus, when we say Bacillus clausii is not useful in acute diarrhea because
we don't have study to support. And you require, see, it's very easy to make a study. So I've got 10 kids in a daycare center, and the incidence of diarrhea in the first month was 10%. And I start a probiotic, and in the second month, the incidence is reduced by 50%. And I published the study, and you read it, the beginning and the end, and you are very happy about it. What is essential here, you need to understand that in this 1 month, the water which was supplied by the tanker is now coming through the tap, and they have an aquaguard there. There was only one IABI initially. Now there are 10 IABIs managing each kid. So you have to take all these variables when you study a report, which is not being done. So if you have something which is very superficial, it's not accepted by the world bodies. And that is why Clausy is in a lot of disrepute. Otherwise, they have all the mechanistics for a perfect probiotic. But the unfortunate thing is we don't have studies. Whereas GG and Saccharomyces rule the roost, and the safety profile is tremendous. The only problem with GG is the stability issues. So you have to buy a product which is from a good company. Like if you take Visalak GG, it's Christian. I mean, the manufacturer is very important because the structure is also very important.
Fine. So I think we'll come to take-home messages, sir. Sir, you want to say something?
Sir, my one question, please.
Yes, sir.
Sir,
Come in online.
One question, can we use combination of the probiotics? One. Second, since Bacillus clausii has been introduced quite long back, and after that we come across GG and Saccharomyces boulardii. But these two, Saccharomyces boulardii and GG, they got into the books, but Bacillus clausii did not come in the book till today. May I know if the Bacillus clausii is well accepted, as told by another dignified speaker? Why this could not come into the textbook, and why the importance of GG and Saccharomyces boulardii they are into the textbooks?
Sir, he answered both your questions. So as far as combination is concerned, there is something known as VSL, which is used in inflammatory bowel disease. So that's a combination. And the reason for clausii not coming in textbooks, as he said, is that the studies which have been done so far for clausii are not good quality studies, and they are not enough in number. So for that reason, as far as good hardcore evidence is concerned, clausii is still lacking behind the other two. That is what Sridhar just said, right? Thank you, sir. So we just quickly come to the take-home messages. So diarrhea is a nutritional disease. We must remember one worsens the other. So we must look at both the aspects. Etiology and management are different in a healthy child and a malnourished child. So let's make this very important observation at the beginning of treating the patient. Acute diarrhea can sometimes be parenteral as when it presents at the onset, but is self-limiting with appearance of the other symptoms of the primary disease going on, right? Antibiotics are necessary only for invasive bacterial infection, and chronic malnourishing diarrhea is very complex. It is multifactorial, so there can be an element of infection, malabsorption, some immune dysfunction, some bile acid irritation, drugs, and so many other things. So we must look at all aspects while managing and not just one new antibiotic. And finally, we must think of when nutrition has to be taken care of. It may be beyond the routine conventional nutrition. So it could be elemental or semi-elemental, semi-digested products, etc., and homemade good alternatives, right? So I think with that, that's the end of our presentation. If there are one or two questions, we can take that.
Sir,
can I have one question last? Can I have one question?
Sir, 1 minute. Local person is speaking, then we'll come to you. 1 minute.
So just wanted to know about zinc. I mean, how many days it is advocated? Secondly, suppose some child is having every month, maybe every month 2-3 times. So every time zinc is advocated, every time the diarrhea for how many months?
The question is, how is his growth? Okay, if his growth is all right, you find a cause which could be diet related, functional, it's not pathological. But if he's slipping on a growth chart, then you better take a note. What is more important in recurrent problems is, how is the patient in between the recurrence? If in between the recurrence he has caught up what he has lost and he has maintained the growth, don't do much about it. Find out some excuses which are more physiological than pathological. But if in between is not all right, he passes few loose stools periodically, but in between he's irritable, he's not eating, he's not playing, then you have a problem of growth slipping out. You need to investigate.
So he's also asking whether zinc every time. What is the role of zinc? I mean, you keep repeating zinc.
I felt that zinc has come in diarrhea only because large number of our population is malnourished. Okay, excess of zinc is also bad. So every time to have 1 or 2 loose stools and then give zinc for next 10 days is not a good idea. So zinc is necessary for malnourished children more than well-nourished. And if I see a well-nourished child with diarrhea, even 10 times, I need not give zinc. But the guidelines are meant which are applicable to the majority in the population, and you may have to decide whether those guidelines are fit for your patient. So most of us get patients who are reasonably hygienic, understand what to give. They are not malnourished. Zinc may be an option. And if I've given zinc in the last 3 months, I may not give it again. So I think guidelines are not something that you verbatim follow, but they are good for the masses. But each one of us will apply to where we stand, right? If a growth is all right, 2-3 days of loose stool, I don't worry about anything at all, right?
Yes, online someone wanted to ask.
Last question.
Yes, sir.
Is there any role of lactobacillus acidophilus, which is there in the market for last more than 35 years? Is there any role of lactobacillus acidophilus Sporlac tablet? Nobody has told anything. Nobody talks of lactobacillus acidophilus, which is there in Indian market.
One of the most important thing when you pick up a probiotic is know all about the probiotic. So you need to know the genome, you need to know the stability, because they can transfer resistance. That's number one. So whenever you pick up a probiotic, you have a number along with it, some ATC 1770 and things like that. They are the repository number. They are kept in a culture, this thing, and they are studied every year. So if the stability is affected and you don't know much about the probiotic, you've got no business to use the probiotic. So use only probiotics which have been studied and whose genome stability is well known.
What
so
is
if you
your
pick up
your opinion about acidophilus, that's what I'm.
So that is why I'm trying to tell you this. So that could be a placebo effect.
No.
Are you understanding what I'm trying to say? So
why is
the
there
dosing is also very important because you have 10⁻12 organisms per ml. Now, if you add a pinch of salt to a bucket of water, you can't expect that water to be salty. So the dosing and the genome, you need to know all about your probiotic before you use it. So that is why the repository number and the genome stability and the antibiogram. Why the antibiogram is, if it translocates, you know how to treat it. So if I have a GG translocating, I know penicillins work. If I have the Clausy, I know the quinolones work. If I have Saccharomyces translocating, I know the azoles work. So that's the way it is.
So the duration to use, once we have started using probiotics, for how long we have to use? Hello? Yes, sir. The duration, once we have started on probiotics.
So that's what I'm trying to say. This is not as easy as the way it is put. What you need to understand is, what are you treating? And based on what are you treating, how early are you treating? So if you're dealing with a viral diarrhea, you start pretty early and you continue for at least 3 to 4 days after the diarrhea has stopped. The same way the antibiotic associated conditions, you need to start with the very first dose of the antibiotics if you want a response, and continue for at least a week after you stop the antibiotics.
And organisms in different preparations, probiotic count is different in different companies.
So that's what I was trying to say. You require a particular amount. That's why we now start looking at probiotics as drugs. So you require a dosing because you require minimum 5 billion units for any effect. So you require a specific dosing, you require safety, you require interactions, you need to know with what to give. It's very essential, the vehicle.
Thank you everyone for interacting so much, even from all the 14, 16 centers that were looking at us. And we now stop this program and we hand over to the organizers. Thank you very much.
Sir, there is one small question. I'm a senior pediatrician.
Yes, sir.
I'm talking
Yes,
to
sir.
you.
Hyderabad, sir.
This question is for Amdekar, sir. I have used folic acid for chronic persistence. What is the role of folic acid? What is your experience on folic acid in chronic diarrhea?
Folic acid in chronic diarrhea. Folic acid in chronic.
I think when there is a chronic diarrhea, there are multiple nutrients which may not be absorbed. So the reason is we don't look at individuals, we look at almost the whole spectrum, and in which you cannot just isolate one over the other. But if there is an evidence of a folate deficiency to begin with only, it could be even aggravated. The question is, you look at in a chronic diarrhea and a chronic malnutrition, every aspect of every item of food that may not be absorbed, and it is right to kind of supplement if necessary, but not supplement necessarily in terms of drugs. Largely in terms of diet, which contains almost everything. But if you are doing a CBC and you have a strong evidence that you have a macrocytic anemia, you will certainly look at a folate and B12 specifically. So I don't think I want to separate each one as the need for supplement. I would say in general, yes, in which even folate comes in.
Does it help in repair of intestinal epithelium? Folic acid. I have a studies where it helps in the repair of the intestinal epithelium. Can you answer my question, sir?
Yeah. So we got your question. So we will have to look deeper into the study, whether the study has been nicely designed to obviate all other factors. What Amdekar sir is trying to say is, it is going to be difficult to find a child of diarrhea whose sole problem is folate deficiency, and that is why the moment you give folate, his diarrhea is controlled and the child is better. It is always a multifactorial problem. So to isolate one and pin the cause on that and say that this helped is not going to be easy. But anyway, we will look into your study and we'll discuss it at the next meeting. Thank you so much.
Dr. Chokhani, please, one
Yes,
question. Sir, we are talking a lot of the translocations of the probiotics. As far as I know, sir, it is definitely helpful in respiratory infections and sometimes in hepatic encephalopathy. What is the opinion of the great speaker?
Can you just repeat the question? I was a bit...
I am Dr. Jagnani from Ranchi, sir. Ranchi branch is really very delighted seeing you people on the webinar series, particularly Dr. Ambedkar, Dr. Chokhani, sir. My question is that there are important translocations of the probiotics and helping in case of respiratory infections and hepatic encephalopathy. What is your opinion on that?
No, we don't allow a probiotic. It's a local effect. And the products that are produced by the probiotic, what are now called as postbiotics. So now we are moving into an era where we don't want to use the organism. So we use something called as parabiotics that are killed organisms for respiratory. You must have heard about it. And we use organisms that produce the short chain fatty acids like butyrates, acetates, propionates, what are called as postbiotics, which are extremely beneficial at all places, right from your CNS to the skin. So we don't allow any probiotic to translocate. It's a local effect.
Thank you, sir.
And the metabolites that are generated by the probiotics are beneficial.
Thank you, sir.
Yeah, good afternoon, respected delegates, all live locations of 14. What we request you, all of you, that whatever is your questions, kindly give it to our local team who is present over there. They will send it to us and we'll try to work it out on this. Since the time is short, we would like to end this program. So I'm Narendra Joshi, AGM Sales on behalf of Torrent Pharmaceuticals UR Division. I would like to thank all of you. You have taken out time from your busy schedule for this CME. On behalf of Torrent, I thank you for your active participation in this live CME conclave. I would like to thank Dr. Amdekar sir and Dr. Chokhani sir for giving us an opportunity to associate with you, sir. Thank you very much. The scientific session conducted by both of you was a really scientific feast to all of us. The way delegates were involved and interacted, the session was really a treat to watch and listen, sir. Thank you very much. We would like to thank all the delegates of 14 live locations, those who have actively participated in this session. We would also like to thank Clinics India team for ensuring an excellent execution, all the arrangement at all 14 locations across India, pan-India. Thank you very much, team. I would also like to thank our product management team, Kedar and entire team, and also my sales team for their coordination and making this program a grand success. My team and I once again thank all of you, and we look forward your valuable continuous patronage for a wide range of products like Vizelac GG. I'm sure that your support will make our relationship more stronger. Thank you very much. Thanks a lot. All of us can join for lunch. Thank you so much.